Hello, everyone. Welcome to the 2023 IJLCD annual lecture. My name is Paul Conroy, and I'll be chairing this morning's session. So I think we're expecting quite a high attendance this morning, so I'll just allow people to kind of settle in, and our numbers are going up very, very steadily. So we're being very kindly hosted this morning by the Royal College of Speech and Language Therapists in the UK, and we're using their Zoom platform. We've had absolutely fantastic support in organising this event from our RCSLT colleagues, specifically Justina Zeller, Jasmine Padar, Hannah Wright, and Amit Kulkarni. So you can see our topic for this morning on the screen, and I think we have had several hundred registrations, which is a testament to the range and the depth of interest in this topic. So we're really, really excited. What I'll do is, just as we allow the numbers to kind of increase and people to settle in, we're gonna have a 2-hour session on this really, really important and interesting topic. But before we start kind of properly, what I'll do is just give a little bit of orientation and a little bit of explanation about the journal itself. So I could move on to the next slide, please. So ways to get involved in our journal. So, obviously the journal doesn't really drop onto your doormat the way it used to a few years ago, since things have gone more online, but we like to think that it's still a very tangible part of your experience and identity as a clinician or academic. So we're really always very, very keen to hear from would-be authors. If you are considering submitting a paper from, say, a master's project or a PhD project, we are very, very willing to discuss that with you. We are always keen to hear from potential reviewers. So we want an ideally a mix of academic and clinician reviewers, and we can offer some support and some guidance in the process and in the steps within getting some skills as a competent and confident reviewer. We are a team of 7, which I'll just mention in a couple of minutes, but just for now to say that we have fixed terms in terms of the 7 on the editorial board who manage the process of getting papers to publication. And because we have fixed terms, there are very frequent opportunities that people, change, people move on. Around every 18 months to 2 years, we advertise for a new editorial member. So please, if you are interested in getting an insider perspective on the publishing process and the experience of editing for a journal, please contact us in that regard as well. And then lastly, we have a set of advisors who advise us on specific papers. So we're always keen to hear from topic experts who can contribute to our executive editorial board. So the next slide, please. So we offer a couple of prizes that I'll just mention in terms of both student awards and a best paper prize. So this process for the best paper, the so-called editor's prize, is actually done very, very objectively, and we do it in a blinded way, where we rate all of the papers. Well, we rate papers from the previous year, and then where the editorial board get a consensus, we then rank them again. And the very clear winner from 2022, so it's the prize we're awarding now in 23, was this paper. So it's by Dr. Camille Painter and colleagues. Camille is from the University of Melbourne, and we had the pleasure of telling her about this award a couple of days ago. So her study was entitled "The Impact of Communication on Healthcare Involvement with People Living with Motor Neuron Disease and their carers," a longitudinal qualitative study. And for the disease, which it can be quite hard to access people in terms of numbers, this managed to recruit 19 people with motor neuron disease and 15 carers. And it's a fantastically rich and interesting and helpful contribution to our literature on this important topic. So if we could go to the next slide, please. So our student prizes, yes. So we do this. This is really successful. It's presently a UK project, but we could consider extending it in the future. But basically, last year were submissions from the various universities who train speech and language therapists within the UK. And from those submissions, we had two winners. One was Nihal Amalu from Reading University. So Reading is just in the southeast of England, quite close to London. And Nihal's topic was diversity, equity, and inclusion in speech and language therapy. And this was the winner for the research category. And Nihal received a cash prize, a letter of congratulations. We decided to go with both of those rather than either or. And we do offer support to students to submit their paper for publication in the journal. And that just sometimes happens, but it did happen last year, for example, where we published a paper on a functional numeracy study from UCL. So I think can be a really amazing start to a new therapist's career. And then the other student prize was to Christiane Pollock, and Christiane was based in Plymouth Marjon University, so in the southwest of England and the UK. And Christiane's topic was the development of a website to support better communication interaction in learning disability services. And this was the winner of the alternative project category. And again, there was a cash prize and a letter of congratulations, which hopefully were valued by the students. So just to kind of emphasize some of the kind of outreach and some of the ways of becoming involved in the journal, really. So if we can go to the next slide, please. So just to put some faces to some of the names you may see if you interact with the journal. So as I mentioned, we have a team of 7 colleagues who manage the editorial process. We are the editorial team. So there is myself, Professor Lindsay Pennington, and Dr. Joanne Cleland. So Lindsay is based at Newcastle University. Joanne is based at Strathclyde University in Glasgow. I'm based at the University of Manchester. And here are our other colleagues. Dr. Jackie McRae is at Kingston University in London. Dr. Silke Fricke is in Sheffield in North England. Dr. Saloni Krishnan is based at Royal Holloway University in London, and Dr. Mark Jays is based at Manchester Metropolitan University, quite near to me in the northwest of England. So we are the team who manage the process of looking at papers, sending them out to reviewers, collating the decisions, checking revisions, and seeing papers through to their final published state. So great, if we can have the next slide, please. So just to say, it's been delightful to work with our presenters who are presenting today, because we've had an ongoing project really on a special issue. So this special issue will be published within the journal very, very soon, within months. And it is on this topic of clinical management of cognitive communication disorders. And there will be around 14, possibly slightly more papers, which will be a really up-to-date snapshot of developments and innovations within this really quite exciting clinical field. So if you can go to the next slide, please. Okay, so today, we have 3 substantial presentations, around 20-25 minutes each, and that will take us up to round about 11:15 approximately, and then we'll have some time for more of a panel discussion, hopefully more of a wide-reaching discussion around this clinical topic and possibly others. But within each presentation, we'll have some time for specific questions. So we'd be delighted to hear from anyone with a specific question to each presenter as they present, and then within their kind of half-hour time slot. And then we'll kind of open it up to more broad-reaching questions towards the end of our time together. So our staff, our colleagues, Justina and Jasmine are on hand, and Hannah are on hand to help with any technical issues. Please don't hesitate to contact via the chat button. Please send in questions and answers. For people who've got my mobile number, you can text me a question if that helps as well. But basically, we'll probably mostly go from the chat function here, and they will be curated questions. So in other words, I'll kind of present the questions on your behalf, which is just, you know, it does lack a little bit in terms of interaction, but hopefully we can make the whole operation as smooth and reliable as possible in doing that. So we are recording the session. We always make these available on the IJLCD website and on the RCSLT website. And then we would really be grateful. It's always nice to get your feedback, you know, what worked for you. There's been a lot of hard work invested in today's presentation, but we would like to hear what it was like from your perspective, and any feedback and all feedback gratefully received. So use the chat function to offer feedback as well, please. Okay, so we can move on. So lovely. So our presenters today are all from the University of Sydney, and they are Professor Leanne Togher, Dr. Rachael Rietdijk, and Dr. Melissa Liss Brunner. And it's an absolute pleasure to have worked with them and to be able to listen to them on this absolutely, you know, really fascinating and quite radically, you know, rapidly evolving clinical topic. So, so without further ado, I think I'll hand over to Leanne, and we'll start with the first presentation.
Thank you, Paul, and thank you so much for the opportunity to have this honour to present this lecture. We were all thrilled and excited when we received the invitation, and I'm very, very happy that I can share this with my colleagues, Rachael Rietdijk and Liss Brunner, because it really is a team effort, everything that we do at the University of Sydney, and it seemed only right that they present the really world-class work that they're doing. Today, I'll be presenting on what are called the INCOG guidelines. The INCOG guidelines are the recently published International Cognitive Rehabilitation Guidelines, and they're the second version. They're an update, so I'll be giving you a bit of an overview of those, as well as just briefly introducing what we mean when we're talking about CCD, or cognitive communication disorders. Can I have the next slide, please? In Australia, sorry, if we can just go back to the red slide, thank you. In Australia, we typically acknowledge the traditional custodians of the lands upon which we meet and work and study, and the University of Sydney has a range of campuses on Gadigal land, and I'm working actually at the moment in Western Sydney, which is on Darug land. So we pay our respects to those who've cared for and continue to care for country, and pay our respects to elders past, present and emerging of those lands. Can we have the next slide, please? So I'm going to be talking primarily in my talk about traumatic brain injury. We'll be covering TBI and acquired brain injury, or ABI, as well during our lectures today, but the INCOG guideline is really focused on TBI. And when we see people with severe TBI, so I'm not really talking about mild TBI, I'm not talking about concussion in this talk, I'm talking about moderate to severe TBI, we see that these people have a myriad of difficulties. They obviously have the immediate medical issues that arise from having a severe brain injury, but additionally, they have a number of changes. They're very complex and often lifelong disabilities that these people face. And so we see changes in their physical and sensory abilities. They frequently have visual impairments, for example. They can have changes in their behaviour and their personality, and these can be devastating for family to deal with because the person doesn't seem to be the same as what they were before. And notably, and of interest to us as speech pathologists or speech language therapists, are their communication difficulties. And they're actually, these communication problems are very common, and so, fluctuate over time, but nonetheless can persist for years. So we see traditional, what we think of as traditional communication problems, such as dysarthria, that can occur in up to 60% of cases. Aphasia can be very common, especially in the early phases of recovery, and that often resolves to look a little bit like an anomic aphasia, because these people can have word finding problems long term. And one of our colleagues from our lab at the University of Sydney, Liss, published a paper in 2019 which described the recovery of these aspects over the first year of recovery. So they do evolve, but some people remain with persistent issues. But by far, the most common problem these people have are conversational skills problems. And these, I think, are possibly the most devastating of issues for them. So they have what we call cognitive communication disorders. They're also referred to as having social communication difficulties. There's a lot of terminology, cognitive linguistic disorders. There's quite a list, but we've settled on the term cognitive communication disorders, which is what we'll be talking about this evening. And we also are seeing disorders of what is called social cognition, which I'll be covering in my talk as well. And that's been a more recent issue that we've been able to identify. Would you be able to forward to the next slide, please? So this definition comes to us from the American Speech Language Hearing Association. It's getting to be quite old. It's nearly 20 years old, this definition, but it's a good definition in that it pulls together what we're talking about when we're thinking about cognitive communication disorders, and that is that it covers both what we know about as communication, which is, you know, listening, speaking, reading, writing, gesturing, but critically it's how cognition, the interplay between cognition and cognitive processes and systems, and how impairments in cognitive systems can impact on communication. And so cognition is referred to here as attention, perception, memory, organisation, and executive function. And combined, when these areas are affected, we can have difficulties with behavioural self-regulation, which means people may have difficulty having awareness, they may have difficulty controlling their behaviours, they can have difficulties with social interaction, activities of daily living, learning, academic performance, and vocational performance. So cognitive communication disorders are complicated because there are so many variables involved when we're trying to tease out what is it that's going on with these individuals. Can I have the next slide, please? So what do we do about people with cognitive communication disorders? How do we manage the sorts of issues that they have, and what guidance is out there? Well, we have had some access to resources such as the ERABI, the Evidence-Based Review of Moderate to Severe Acquired Brain Injury. This comes out of Canada and Robert Teasel's lab in London, not London, UK, but London, Canada, London, Ontario. And there are a series of modules that provide some guidance about how to manage communication disorders after brain injury. We've also, in 2014, we published the first INCOG guideline, which was our first detailed look at the literature. We had 670 papers that we went through, and as an international consensus group, we came up with a series of papers. There was enough for cognitive communication to have its own dedicated paper, and so that was really our first, I think, comprehensive summary of the work that has been done out there to assess and treat cognitive communication, and then for us to be able to make some recommendations. Can I have the next slide, please? So the questions that I'm going to pose to you today and for you to think about are these. So what is the current evidence? So what has happened since INCOG 2014, since we published that first paper in the field of cognitive communication and social cognition disorders? What treatment approaches are recommended for use with people with cognitive communication disorders with moderate to severe TBI? And the final question I'm going to address today is what tools are available to help us with our clinical decision-making and to help us audit clinical practice. I have the next slide, please. So the answer to all those three questions can be found in this set of guidelines, INCOG 2.0. I just wanted to point out here the authors on this, next iteration. So Jacinta Douglas, Lynn Turkstra, Peter Bragg, who's a methodologist, Mark Bailey, who's a physician at the head of Toronto Rehab in Canada, Sturgio Keita, Monsford, Teasel and Wiseman Hakes are all other international, I won't go through all of them, but they're all international researchers and clinicians who work in the field of TBI. And so we really came from Canada, Australia and the United States and came together to write this paper. Can I have the next slide, please? And we were part of a much bigger team. So this this QR code here will take you to, should take you to a link to all the papers. So we have 8 papers, and as I said, we've got a very multidisciplinary group here of researchers. Can I have the next slide, please? This is just a list of those 8 papers. So this formed a special issue of the Journal of Head Trauma Rehabilitation, the January-February issue this year. And we had, as well as addressing this particular issue of summarising what has changed from 2014 to now, and that covers all domains. We've got a detailed methods chapter, and then we looked at how to manage people when they're in post-traumatic amnesia. So that had its own paper. We had another one about attention and information processing speed. Further one to do with executive functions. I led the paper to do with cognitive communication and social cognition disorders. And then we also had one to do with memory. So it's quite a comprehensive summary of the current evidence in those papers. And then Peter Bragg led a paper about the future and thinking about future perspectives and where we might be going in cognitive rehabilitation. Can I have the next slide, please? So this is just to give you an indication of the process that we went through when we produced the INCOG guidelines. So as I said, we'd already had a comprehensive search up until when we published the first issue in 2014. We reconvened the panel. This actually happened in COVID. So we were doing all of this online as everybody was. But we had a team. This was funded through the Canadian Ontario Neurotrauma Foundation. They funded research assistance so that we could update the literature search. I'm not going to go through all of these steps in the interest of time, but we definitely went through with a view of how we're going to map the updated evidence onto what we'd already done in the past. So what we mapped it onto the existing matrix. We had a series of working group meetings where because some of the items that I'm going to talk through were consensus. They were opinion consensus recommendations, and there were a couple of new recommendations I'm going to talk about that really have arisen not from the literature, but from where we are in using technology and our cultural awareness, for example, that really led to us thinking we needed some new recommendations. We finalised those, and what we're going to do, Jenny Ponsford's leading a paper, a study where we're currently going to be auditing practice internationally to see, you know, what are people doing now, especially now that we've published these, and we plan to update these. So they're not living guidelines, and they're not constantly changing, but we're certainly intending on continuing to update them. Have the next slide, please. So we have a grading system that we've used to grade the level of evidence in each of our papers. Level A means that we had at least one meta-analysis, systematic review, or a randomised controlled trial of appropriate size with a relevant control group. Level B evidence would consist of cohort studies that at minimum have a comparison group. So this could be a small randomised controlled trial. And we also wanted to include well-designed single case experimental design studies as level B. And then level C was where we really don't have a lot of evidence, but we had expert opinion based on our experience. There could also be uncontrolled case studies or series included here that may guide us. Next slide, please. So in total, we made 80 recommendations, and inclusive of those, we had 27 new recommendations. So I'm not going to obviously talk through all the recommendations because that would be a full day workshop, but what I'm going to cover for the rest of my talk is the 9 recommendations that we had for cognitive communication. Next slide, please. This is just a snapshot of the, obviously the front page of the article, just to point out that as well as the new evidence, I'm going to cover the algorithm that we developed, which is our clinical decision-making tool, and that is included in this article. And the other thing is the audit tool, which is to help with identifying how well services might be complying with the guideline that we've published. Next slide, please. So basically, since 2014, we found 26 new papers that were related to cognitive communication, and we had 12 new references for social cognition. And the social cognition papers were from 2000 forward. That's just when they started appearing. So it's a fairly new phenomenon, social cognition. So we had 9 recommendations. We had 5 that we updated, and there were 4 new recommendations. And the 4 new recommendations addressed things such as cultural competence training, group interventions. We had sufficient evidence to make a specific recommendation about groups, telerehabilitation, and finally, there was the new social cognition management recommendation. So in summary, cognitive communication has 8 recommendations. 3 of those were level A, 2 were level B, and 3 were level C. And social cognition had 1 recommendation, and that was based on level A evidence. Next slide, please. So if we just start with our first recommendation, this is really an overarching recommendation describing all the variables that should be considered when one is undertaking cognitive communication disorder management. And what I want to highlight with this particular one was that we added some wording in. There were no new references to support this. It's a level B recommendation, but we particularly wanted to emphasise that clinicians should be considering physical, sensory, and psychosocial variables when they're seeing someone with a traumatic brain injury with CCD, and particularly thinking about the impact of dysarthria, balance disorders, hearing and visual disturbances, and that they should be dealt with, sleep wake disorders, and the issue of pain. So they were the kind of sensory disturbances we were thinking should be addressed. And then particularly calling out psychosocial issues such as anxiety, depression, post-traumatic stress disorder, which is very common after severe TBI, and how these will impact on the other cognitive impairments that will in turn impact on communication. Next slide, please. Our second recommendation was it described the first in the INCOG 2014 paper really talked more about pre-morbid variables, and we talked about, you know, a person's background and their preferred languages, literacy, language proficiency, those kind of issues. But what we wanted to update in this INCOG guideline was the specific mention of cultural awareness, and to be culturally aware and to be using culturally appropriate communication resources to facilitate healthcare interactions. And this was because of I think it's fantastic that there's been a bigger emphasis on diversity, equity, and inclusion in the field of TBI, and I think in speech pathology more broadly. So making it clear that our rehabilitation programs are culturally responsive, and that we are thinking about cultural background and being culturally aware. This is a level C recommendation, obviously, because it was really more about our expert opinion. Can I go to the next slide, please? Because we talked about this quite a lot in our meetings, and we decided that it wasn't enough just to say that programs should be culturally responsive. Obviously, the follow-on from that is that staff need to be trained. So we've recommended as a separate, and we've put it up right, you know, early, number 3, that staff should receive cultural competence training. To be honest, there's not a lot of readily available resources for this in speech pathology world. Happily, ASHA has produced a cultural competence check-in page, which does have some self-directed learning activities. And so we wrote about those in the paper. Here in Australia, we do a lot of cultural competence training, but I'd say that's varied around, even around Australia and probably around the world. So this was a new one that we thought needed some attention. Can I have the next slide, please? Cognitive communication, number 4, is where the bulk of the recommendations are about the various treatments that we have come up with from our searches. But and I'll talk about those in a little more detail in a moment. But the overarching recommendation is that intervention should focus on improving and restoring cognitive and social communication functions with gradual reintegration to daily functions and productive activities. Treatment should be about the person's everyday life, is the short summary of that one. It should be personalised. It should be about what they want to get back to. It should not be about checklists, workbook sheets, brain training exercises. We've recommended against that in this paper. They should be individualised and really be looking at that person's context. Can I have the next slide, please? So within that overarching principle, there were some key new treatments that we came across. There was new evidence for communication partner training, which I'll talk about briefly in a minute. Communication strategy and metacognitive awareness training there are some specific training programs now that were new that we were able to write about. reintegration to daily functions, productive activities, modifying the environment, assisting with adjustment to impairments is another way to approach treatment. We came across communication coping treatment, which was written about by Jacinta Douglas, confidence, self-esteem and identity formation. And then we said it was really important for there to be education and information provided about what the nature of cognitive communication disorders are and the impact of those for the, so the education should be for the patient, but also for close others and other communication partners. Can I have the next slide, please? So I'm not going to go into this in too much detail because Rachael Rietdijk, who's going next, will talk about her work with communication partner training. I did want to highlight this program called Interactability, which is free, and that QR code takes you to the interactability training if you're interested in undertaking it. This was a new training program we've developed in our lab, and it just adds to the suite of tools that we have available for communication partner training. But there was significant new work since 2014 in CPT. We had 2 systematic reviews and 3 randomized controlled trial studies. So we've got strong level A evidence now for this one. Next slide, please. This was the one about metacognitive awareness training. Once again, we've had 3 reviews, and there was some pilot work that came out of the University of Queensland here in Australia. So we can make this recommendation at level A. This impact training program is one example of a manualised structured program that incorporates those principles that I was talking about previously, but really helps the person with brain injury focus on particular social communication goals that they would like to work towards, and then using metacognitive strategies, which basically is plan, goal, do, review. In Mark Ilvasaker, when he used to write about it, it's planning ahead of time what you're going to do, make a plan, do it, and review it. So it's really that iterative process of reviewing your progress. So there was pilot work with this. You know, we look forward to there being more RCTs in this area as well. Next slide, please. So cognitive communication number 5 was really about the fact that treatment should be individualized and goal and outcome oriented, and it should be particular to the person's where they live, where they study and where they work. So that recommendation remained unchanged from 2014, except that we added in goal attainment scaling, because there has been considerable work done since 2014 that has demonstrated goal attainment scaling is a highly effective way of measuring progress. Next slide, please. This cognitive communication 6 is in relation to recommending that AAC should always be available. It should be routinely offered within the context of a person's everyday environment. There were no new RCTs in this area because I think of the nature of finding groups in this area. I think it's very difficult. But nonetheless, we re-emphasised that people should have access to AAC, and there should be access to training as well. Next slide, please. Cognitive communication 7 is about group therapy, that we've now got level A evidence to support groups. There's something magical about doing a group with people with TBI if you're able to put a group together. These treatments that are listed here are some examples of new treatments that have been published, and if you're interested in any of them, please go to the paper. We do give a bit of a description of them in the paper. Next slide, please. We do have a new recommendation about telerehabilitation being efficacious. at level B evidence, and I'm not going to talk about that one anymore because Rachael Rietdijk is going to cover that one, so you'll hear more later from her. Can I have the next slide, please? And then finally, we have social cognition number 1. So we certainly recommended that clinicians and speech pathologists should consider evaluating aspects of social cognition. And by that, we're including emotion perception, theory of mind, and what we're calling emotional empathy. We made a clear recommendation that computerized social cognition treatments should not be used because there is a lack of evidence of generalization to real life activities. Next slide, please. And this is just some of the evidence that we discovered. So this is a hot topic, right? So this is what's happened since 2000. We had 5 reviews. We've had some RCTs and then some other, like the Castle 2019, 2020 papers. They're very recent. This is very recent work. But we could see that there was evidence to suggest there are interventions around that can improve emotion perception, perspective taking, theory of mind, and changing social behaviour. So I expect there'll be a lot more in this field moving forward, because you could just say this was an area where there was a lot of new and exciting publications. Next slide, please. So this is a very complex slide, and I don't expect you to be able to read all that little writing, but what it is this actually is the entire INCOG guideline in one drawing. And what it's designed to do is to help guide clinical decision making. So it starts at the top left, where you get a routine referral to a speech language pathologist, and then you evaluate the communication, and we specify what needs to be taken into account. If they have a severe communication disability, AAC should be involved. If they don't, you need to consider cognitive communication rehabilitation. And then if we move sideways, what types of cognitive communication rehabilitation? Well, we've got 3 fairly strong areas from our recommendations: that there'd be individual or group therapy, and that should be client-centered goals and tailored to the individual. Communication partner training, we can recommend with level A confidence, and then social cognition training. So there are sort of 3 key areas. Might move on to the next slide in the interest of time. And this one, excuse me, is the audit tool that we developed. So this is if you're wanting to review your clinical practice and you're wanting to go through your medical records, how would you be able to tell whether your service was complying with the INCOG 2.0 guideline? And there are a number of areas that we can look at, such as if AAC should be prescribed. Is it mentioned? Are there systems in place? Has training been provided, for example? If we're wanting to see that participation in everyday life is being measured, how can we, that we should be able to see evidence of that in someone's medical record or in their files. So, and this is multidisciplinary as well. So while we expect speech pathologists to be involved, obviously it's a very multidisciplinary field working with TBI. So there may be other professions who are also reporting on some of these as well. Next slide, please. So just in summary, we do have some nice changes since the 2014 guideline, with a stronger evidence base for communication partner training. We have level A support, which I think is reassuring for us as speech pathologists, as well as CPT, to be looking at communication strategy and metacognitive awareness training, conducting group treatments, and looking at social cognition. And we do have these tools, this algorithm, for clinicians and for students as well, to help them think about the complexity of cognitive communication disorders and also the audit tool, which gives us a brief way of auditing clinical practice. Next slide. I think that might be it for me. So I did want to thank Professor Paul Conroy and the Royal College team and the IJLCD team for this invitation. This is a shot of the quad at the University of Sydney. You can see why we feel so close to our English colleagues, because it is a little bit of England, I think, when you go into that quad. But it's been a joy to prepare this lecture, and I want to thank you very much.
Thank you very much, Leanne. That was so comprehensive and interesting, and so many questions, really. But yeah, so we'll have some time at the end as well as now. So just a couple of practical issues have come up about, the QR codes not presenting very well on the screen. So just to reassure people, we can send those separately so you can properly access them. So a question from Victoria Mayer, if that's okay, Leanne. So Victoria's point is, intervention will obviously vary according to where in the recovery journey the person is. So what do you think should be prioritized in the early acute, post-acute inpatient phase versus discharge or 1 year later? Maybe we'll just start with that part of the question.
So I think in the very early stages, some of the treatments that I was recommending under cognitive communication number 4 may not be that relevant for a person in the post-acute phase, because they may have limited awareness. They're just dealing with having had the injury. So I think for people at that stage of recovery, I think it's important that they get some early education about what's happened, and that's certainly the case for families. I think some of the communication partner training principles could be given to families in the early phase. But I think a lot of what we're talking about with the INCOG treatments are probably more relevant, as Victoria has said there, post-discharge, even post 1 year, even post 2 years. So it is a real lifelong journey. And I think, group therapy is often difficult to put together when someone's in the inpatient setting. That's often something that's easier further down the track. But I think, making sure that the person has a method of communication, that they've had some education about what has happened to them and what will happen, and the support that's available. And, just keeping those general principles in place of taking that person's pre-morbid life and their context into account, so that we're not madly treating something that may not need to have been treated.
Sure, yeah. I mean, often it's similar within the context of aphasia, that we have more availability of resources early on, and actually when people are more ready and when they're have a more meaningful chance of moving on in their life, there are less resources. So, which does bring up a kind of practical angle, really. So how do you envisage, clinicians incorporating this into their everyday practice? They're in an MDT and they, they've become aware of these resources, and what should they do in the kind of immediate terms to kind of try and make a difference with these?
I think just having the framework that we talked about, and especially a couple of those earlier cognitive communication recommendations about, how are you viewing a patient, and how are you taking account of who they are when you're doing an assessment? Are you personalizing that assessment to that individual? Thinking about, so I think the principles are really important. The cultural awareness, those recommendations that we made, it's really about how you approach everybody in your day. And I think a lot of them are common sense. When we were putting them down in paper, we were thinking, you'd hope that this would be the case, but maybe it's not always the case. So I think having those general principles in mind. I think a lot of the specific training that we're talking about it's becoming increasingly available. So I think as a clinician, I'd be putting together a little toolkit for myself about, and you don't need to always purchase the an expensive treatment program. Some of those general principles are readily available online. For example, a lot of the work that we've done with communication partner training, even if the QR code didn't work, we do have on our Acquired Brain Injury Communication Lab website, there are a lot of resources there and they're free. And there's a lot, and I'm sure Rachael will refer to those in her talk as well. So there's a lot of these principles that, it's possible now to put together a bit of a toolkit and have them readily available for both assessment and treatment.
Yeah, and there are fantastic resources on your website, including lovely conversational clips and all sorts of really valuable things. But I think these guidelines can be really valuable for clinicians, and having, the evidence and that backup, a bit like NICE guidelines in the UK. But maybe for now, Leanne, if I just ask you one more question, which has come up, and then we'll move on to Rachael, if that's okay. But this sounds like it's been a really successful international collaboration. And what kind of makes that work? What are the kind of key ingredients which help that? Because that can be a struggle sometimes, can't it?
It can be a struggle unless you really get on with all the people that you're working with. So I think it was such a joy. I think we all had a strong common goal to put this out there. I think there just wasn't that big collaborative, multidisciplinary collaboration to produce something like this. And I think I think having a great leader, Mark Bailey was an excellent leader of the whole process from Canada, but we all brought an enormous amount of goodwill. And I think we'd all been working in TBI for 30 years plus, and we wanted to make sure that all these ideas got down on the page and got published, and that we were able to, our goal is to make sure clinical practice is as good as it possibly can be and aligns with the evidence. And this seemed like the best way. So I think it's we all trusted each other. There were no egos in the room. Everybody just got on with it, and we all worked hard. But I think it was a brilliant experience to do. I feel very fortunate.
Fantastic, and a really good product at the end. So thank you, Leanne. Great. So okay, so I think we'll hand over to Rachael at this stage. Thank you, Rachael.
All right, thank you, Paul. And I'd like to also echo Leanne's thanks to the RCSLT for providing this opportunity for me to talk about our team's work in communication partner training after TBI. If we can progress to the next slide. I'd like to start by acknowledging that the work that I'll be describing today has been supported by research funding from iCare New South Wales and has been done in partnership with them, and we are thankful for their support. And on the next slide, I'd also like to acknowledge the traditional custodians of the lands on which this work was completed. So the University of Sydney campus where we work is on the lands of the Gadigal people of the Eora Nation. And much of this work as well was also conducted on the lands of the Darug people in Western Sydney. On the next slide, I'll just provide some context about my research. So I'm an employee of Sydney Uni, as well as being an author on the programs that I'll be describing today, but I don't receive any royalties or income from these programs. And on the next slide, I'll share the objective for this presentation, which is to make you aware of some of the evidence-based options that Leanne has already alluded to in terms of providing communication partner training after brain injury. And we'll be particularly looking at the use of telehealth and digital health. So there'll be 4 programs mentioned in this overview: TBI Express, TBI Connect, and some of our future directions in communication partner training that we've been working on: conversability and interactability. And if we can look at the next slide. So Leanne's already given an overview about cognitive communication disorders after brain injury, which we know are really the hallmark communication impairment that can occur for people after TBI, being experienced by over 75% of people after a TBI. And we could see that one of the key recommendations from the INCOG guidelines is to provide communication partner training after a TBI. And the basis for that behind this training and that underpins this recommendation is that we do know that family members and carers of people with TBI can approach conversations in maladaptive ways that actually can prevent a person with a brain injury from communicating successfully. So that may look like the communication partner not providing opportunities for the person to contribute, or it may look like perhaps creating a conversation which is focused around testing the person's memory rather than actually creating a meaningful interaction. So when we're training communication partners, we're looking at decreasing some of those negative patterns and promoting more positive communication behaviours. On the next slide, I'll introduce the TBI Express program, which was the first communication partner training program developed by our team. And you can see it's now been 10 years since 2013 when the outcomes of this paper, the outcomes of this clinical trial of TBI Express were published. The QR code is there. If it works, you'll be able to read more about that particular study. But looking at TBI Express and the content and the aim, so the aim here of TBI Express was for people with TBI and their communication partners to have more positive conversations together. And you can see down the right of this slide the 10 modules of the program, which outlines the core concepts that the training covers. So just to pull out a couple of key examples, number 5, we have collaboration, where we teach strategies that communication partners can use to create more equal conversations, or number 6 there, elaboration, where we teach strategies that communication partners can use to extend the detail and the depth of a conversation. So with the clinical trial of TBI Express, what we did was to compare joint training, where the person with TBI attended training together with their communication partner, with solo training, where the person with TBI attended the intervention on their own, with a control group who didn't receive any training. And what we found was that the joint TBI Express participants did have better outcomes than our control participants. And that was both in terms of ratings of support, meaning the communication partner was supporting the interaction more successfully, and also in ratings of participation in conversations. So that meant the person with TBI was also participating more successfully. Moving on to the next slide, what we started to think about next was wondering what would happen if we changed the ingredients of TBI Express. In terms of how we unpacked that, we found that a paper from Peter Muhlenbrook was really helpful in terms of unpicking the effective ingredients of social communication interventions. So that paper really outlined we needed to consider aspects such as dosage, so how many sessions, how long the sessions were, the format, was it individual or group, face-to-face or telehealth, and what were the components of the treatment. So what were the active processes or the tasks that we were asking people to do that really made up the core of the intervention. So what our team was interested in doing was modifying some of the ingredients of TBI Express to develop a version suitable for telehealth, which we called TBI Connect. And what we wanted to know was whether changing those ingredients would change the outcomes. If we can look at the next slide, you'll be able to see how those ingredients compare between the two interventions. So looking at TBI Express, you can see the dosage was high. It involved a total of 35 hours. And the format involved both a 2.5-hour group session and a 1-hour individual session each week. You can see there was a range of treatment components incorporated in the training, including repeated trials of different types of conversation, clinical modelling, feedback from the clinician, role plays of different communication scenarios, looking at different use of different strategies, problem solving, education, alongside, I guess, that broader component of group process and group dynamics. Where our motivation came from to modify those ingredients in developing TBI Connect was that we were aware, and clinicians were telling us that the TBI Express concepts were really useful and relevant to their clients, but it was difficult for them in clinical practice to implement a program of that long duration. And there were some logistical difficulties around forming groups, particularly for clinicians who might have had fairly small TBI caseloads. So we were aiming to address those barriers when we developed TBI Connect. And you can see that TBI Connect does have a reduced dosage compared to TBI Express, with 10 sessions of 1.5 hours duration, so for a total duration of 15 hours. In TBI Connect, there's no group component, with all of the sessions conducted individually, involving the person with TBI and their own communication partner. And we developed TBI Connect so it could be either delivered in person or via telehealth. In terms of treatment components, all the same components of TBI Express were retained, with the only difference really being the removal of that group process component. So then once we developed this program, we wanted to investigate the outcomes, because we couldn't assume that this new version of the training would have the same outcomes as TBI Express. And we wanted to understand whether delivery via telehealth would have any impact on the outcomes. So I'll explain more about the clinical trial next, where we investigated this, looking at the next slide. So the key paper where we've reported the outcomes of this clinical trial was in Journal of Speech, Language and Hearing Research. And I'd like to acknowledge here the co-authors here. So this was my key PhD study. So you can see here my supervisors were Associate Professor Emma Power, who's based at University of Technology, Sydney, as well as Leanne, as well as two other collaborators, Dr Michelle Attard and Dr Robert Hurd. So in terms of participants, our trial involved 51 participants with TBI, each of whom nominated a communication partner who may have been a family member, a friend, or a paid carer. Of those 51 people, 17 completed TBI Connect in person, 19 completed the training via telehealth, and we also used data from 15 participants in a historical control group that was actually drawn from the original TBI Express study. On the next slide, I'll explain how these participants were allocated to these different groups. So what we did was to follow a partially randomised procedure for allocation. So where a participant lived under 2 hours drive from Sydney, they were randomised to either in-person training or telehealth training at a 3:1 ratio. And that resulted in 17 participants randomised to in-person training and 6 to telehealth training. We then also recruited 13 participants who lived more than 2 hours drive from Sydney, and those people went straight into our telehealth group, which altogether created a group of 19 participants who received the telehealth training. And both of those groups could then be compared with the 15 participants in the historical control group. On the next slide, we've got the inclusion criteria for participation. So we were looking for people who'd had a moderate to severe TBI at least 6 months prior, who were between 18 and 70 years old, with significant social communication skills deficits, who had a home computer with an internet connection and adequate English proficiency to participate in the intervention. On the next slide, we'll look in more detail at what the intervention involved. So we had the same core processes across the two different training modes. The only difference was that our in-person participants received home visits from their clinician, whereas the telehealth participants participated in their sessions over Skype. This was back 2017, where Skype was the latest technology at the time. And the processes in our sessions were guided by a manual, the TBI Connect manual, which provides step-by-step instructions for what to do in delivering each module. So the key steps in each session would be to reflect on positive or negative communication experiences since the last session, to review home practice by actually watching back to a recorded conversation, having a discussion about aspects of that conversation, learning new information relevant to the module topic, making a plan for how to keep practicing at home, and developing a session summary, which we actually sent to participants after the session via email. On the next slide, I'll explain how we evaluated the outcomes. So the outcome measure that we used to evaluate conversation is called the Adapted Kagan Scales, and we applied those scales to both a casual conversation where the person with TBI and the communication partner had a chat about any topic, and a purposeful conversation where they were asked to come up with a list of situations in which communication would be important to them over the next month. The first part of the adapted Kagan scales is the measure of participation in conversation, and that focuses on the role of the person with TBI in the conversation. And there's two components there: the interaction scale, which is about the person with TBI interacting appropriately in the conversation, and the transaction scale, which is about the exchange of information. The second part of the adapted Kagan scales is the measure of support in conversation, which focuses on the communication partner. The acknowledged competence scale, as part of that, is about the communication partner creating a sense of a natural and equal adult conversation with the person with TBI. And the reveal competence scale is about the communication partner using strategies which support the person with TBI to have a successful conversation. For each of those scales, the conversation's given an overall rating from 0 to 4 using a 9-point scale. And for this study, our primary outcome measure that we selected was the adapted measure of support in conversation, reveal competence scale in a casual conversation. So all the conversation samples we collected in the study were evaluated by an independent person who was blinded to which group the sample was from and to whether the sample was from pre-training, post-training or follow-up. We also had a second person rate 10% of the samples and found good inter-rater reliability. The next slide explains how we analysed the data. So our first research question was whether participants who received TBI Connect training had better outcomes than the historical control group. So you can see for that question, we had to combine the data from our in-person and telehealth participants and compare the data of that combined training group back against the historical control group. For our second question, this was more exploratory due to small sample sizes, but we were interested in looking at the magnitude of any differences between the outcomes of our in-person participants and our telehealth participants. So that was a direct comparison between in-person and telehealth data. And those two questions were analysed using planned orthogonal contrast ANOVAs. We'll start looking at the results on the next slide. So looking here, we've got the demographic characteristics of participants. So you can see that overall, the participants were in the chronic stage of their injury in terms of their months post-injury and sustaining, on the whole, very severe brain injuries as indicated by their PTA duration. We found the three groups were statistically similar in all comparisons except for one, which was months post-injury. So we did some further statistical work using multiple regression models and found that months post-injury wasn't a significant predictor of change, and we didn't need to control for that difference in our analyses. On the next slide, you'll see we also compared the groups in terms of their outcome, in terms of the adapted Kagan scales measures. And you can see, looking at the p-values, that the groups were similar across all of those scales in both casual and purposeful conversation. So looking at the next slide, we'll see what happened with these conversation outcomes after the training. So a lot going on this slide to talk you through it. We're looking at change from pre-treatment to post-treatment in casual conversations, where we're asking the person with TBI and their communication partner to chat about any topic. The top two graphs relate to the person with TBI and the bottom two graphs relate to the communication partners. And that orange box reminds you that that particular scale is our primary outcome measure for the trial. Looking at the graphs now, the orange lines relate to the in-person participants, the blue lines relate to the telehealth participants, and the black lines are the control participants. So our first question was about comparing trained participants with the control group. So we're combining here the blue and orange lines together and comparing them with the black line. And the answer to this question was that, yes, our trained participants did have better outcomes than the controls, both in terms of the interaction and transaction of the participant with TBI and in terms of the support provided by their communication partner. Looking at our second research question, if we can progress the slides, great. For that question, we were looking at comparing in-person with telehealth participants. So here we're comparing the blue line against the orange line and ignoring the black line. And on these comparisons, there were no significant differences between the outcomes for the in-person and telehealth participants. Let's look at the next slide, which shows us the data for purposeful conversations at pre and post training. So for our purposeful conversations, we're asking people to talk about a specific topic. So looking again at our first aim, comparing trained with control participants. And for purposeful conversation, we did find that there was improvement on the transaction rating scale for our trained participants, but not for any of the other scales. Looking next at our second question, in-person versus telehealth, we could see there was a significant difference for the transaction rating scale. And while it didn't reach significance, a similar trend was seen for the interaction rating scale. So in general, you can see that our in-person participants are improving here more than the telehealth participants. It could be that this is due to the difference in delivery formats, or an alternative explanation could be that the in-person participants had particularly low scores on those scales at baseline. So perhaps that meant there was more potential for change. So to sum up our previous two slides, so trained participants had better outcomes than controls on 5 of 8 of the measures, which supports the efficacy of TBI Connect in improving conversations. And for the second question, in terms of in-person and telehealth, the outcomes were similar for 6 of 8 of the measures, which supports the potential for telehealth delivery. So I can see, looking at the next slide now, if we can go back to aim 1 on that slide, perfect. So on this slide, we're looking at the question of whether people maintain their skills after training. So we're looking now at tracking how participants' communication changed between post and follow-up. Looking again at casual conversation, we can see our trained participants looking at the blue and orange lines here, they're actually declining in their ratings. And the statistical comparisons show that that decline is significant for 2 of the measures, suggesting that gains in conversations were not actually maintained over the long term after the training. Turning now to our second aim, comparing telehealth with in-person, we can see that both groups follow this pattern of decline with no significant differences between the groups. On the next slide, we'll look at this for follow-up conversations. Oh, I think if we can go back one more slide. Yep, that's it. So looking at aim 2. Yep. So looking at our second aim for purposeful conversations, comparing telehealth with in-person, we can see that both groups follow this pattern of decline with no significant differences between the groups. All right, I think I'll go to our next slide where we're pulling all of this data together and seeing the big picture. Okay, so you might recall the question that I posed earlier about how changing the ingredients of the original TBI Express program might change the outcomes. So looking at the outcomes of these 2 programs side by side in terms of post-treatment data, we can see TBI Connect produced significant improvement in almost all of the same measures as TBI Express, which means we can conclude that TBI Connect did produce similar improvements to TBI Express, looking at these post-training outcomes. Looking at the next slide and looking at maintenance over time, what we saw was that TBI Connect participants did have significant decline on some variables at follow-up, whereas from our TBI Express trial, we actually saw that participants successfully maintained those treatment effects at follow-up. So what we could conclude is that improvements were not maintained as successfully after TBI Connect as compared to the original TBI Express study. So looking at the next slide and unpicking some of the limitations. So one to consider is the impact of the sample size. So the trial was adequately powered for comparison between trained and control groups, but we didn't actually have adequate power for the second aim, where we were comparing smaller groups, smaller numbers with that comparison between in-person and telehealth. So those results should be interpreted with caution. And a second limitation is, given that we did have a non-randomized allocation aspect in the trial, what ended up happening was that all of our in-person participants were within metropolitan Sydney, within 2 hours drive, whereas our telehealth participants came from a range of different locations across Australia, which may have introduced some additional factors contributing to the training outcomes. So I'll sum up the key findings on the next slide. So we could conclude that the rating scales, the that we used, the adapted measure of participation in conversation and measure of support in conversation, were appropriate for showing the effects of the training. We found TBI Connect did produce similar outcomes to TBI Express with reduced training hours and without group delivery, indicating that this is an option that clinicians could consider. However, given that TBI Connect participants didn't maintain their improvements as successfully as in TBI Express, we do need to investigate how we can best support families to maintain communication skills over the long term. And finally, given that in-person and telehealth participants had similar outcomes, this demonstrates the potential of using telehealth to deliver this kind of intervention. On the next slide, I'll just highlight a second paper that arose from this clinical trial where we did some qualitative analysis of interviews with participants on their views of telehealth delivery. And that may be a paper you might be interested in looking into further when you're trying to weigh up those decisions about whether to use in-person sessions or use telehealth delivery with a particular client. If we can move on to the next slide, I'll share with you some of our more recent work in terms of communication partner training and use of digital health. So from 2020 to 2022, our team received some further funding from ICARE New South Wales for a project called the Social Brain Toolkit, which is a suite of 3 tools aimed at more positive communication after a brain injury. And Leanne's already mentioned interactability, which is one of the programs in this toolkit. And we also have conversability, which is another program focused on communication partner training. The third one, social ability, Dr. Liss Brunner will share some further details on that in her presentation. But on the next slide, I'll just briefly share with you some information about conversability, which is an online platform that we've been working on, which we can use for delivering communication partner training after an ABI. So the development and pilot testing of conversability was something that Petra Avramovic focused on for her PhD research, which she completed at the end of 2022. And you can see on this slide the key messages in conversability, which we've actually formulated by analysing the key content in TBI Express and TBI Connect, but thinking about how we could communicate those concepts in more user-friendly language. And that has certainly been something that our participants have helped us to work through in terms of working out what kinds of wording help these messages to be most memorable. So you might remember I talked about collaboration in terms of TBI Express, but in conversability, our new way of talking about that is number 5 there. You can see talk like your teammates. And alongside these updates to the language, this new online platform has also allowed us to integrate some more interactive features to support learning, which I'll show you on the next slide. So the program does include some self-guided online learning modules for each of the 7 key messages that you saw on the previous slide. So some of the activities that people can engage with in these modules are shown here. So you can see the first image here shows you an example of one of the animated videos that we've developed to introduce key concepts. The second image shows you an activity where clients can securely upload a practice conversation to get some feedback from their clinician. And the third image you can see here shows an interactive activity where the participant needs to watch a conversation and tap a button each time they observe something happening in that conversation. The platform also has some specific functions within telehealth sessions, which I'll show you on the next slide. So when you're running a telehealth session in conversability, the session is actually recorded securely in the platform. Looking a little bit below the video there, you can see that you can timestamp key moments when practicing. So, for example, you can see here a positive question asked at 3 minutes and 52 seconds. And you can provide some overall feedback for the client to review. Another feature you can see just under the video there is that there is an automated analysis feature that calculates how much speaking time the clinician had in the session, as well as how much speaking time the participants end had during the session. So our team does have some forthcoming publications describing conversability, so you can look out for those over the next year. Looking at the next slide, I'll just briefly mention interactability, which again is another component of the Social Brain Toolkit aimed at communication partners in the form of a 2-hour short self-guided online course that people can interact with. And I guess one of the key features of that is that it has been really developed for a broad audience, so that can be something that family members, friends, paid carers, or even professionals can access to upskill in how to interact successfully with people with a brain injury. So that brings us to the end of this overview of communication partner training programs that our team has been working on over the past decade. So on the next slide, let's look at a wrap up of the 4 different programs. So we firstly looked at TBI Express and TBI Connect, and both of these programs, as you saw, were supported by evidence from clinical trials. Both have manuals that are available for purchase through the Australasian Society for the Study of Brain Impairment via the website you can see here, and that includes digital versions of the manuals, so that's useful for people located outside of Australia. The key point of differentiation, as I explained, was that TBI Express is a group-based program, whereas TBI Connect is an individual program which has the options of either in-person or telehealth delivery. And looking at the next slide, in terms of our 2 more recently developed programs. So in terms of conversability and interactability, at this stage, both have evidence of positive outcomes from the pilot study research we've conducted, but we're planning future research and progressing with future research for both of these programs. Conversability is not yet available to clinicians, but we are working towards this in the future. And so we'd invite you to register your interest if you'd like us to keep in touch with you about that. And we're also really excited to be working with Naomi Folder, who's a PhD student at the University of Technology, Sydney, who's looking at adapting conversability for use with people with dementia and their families. And finally, interactability, as we've mentioned, is freely available for access. And you can look at further information and consider registering for access using the website you can see there. So thank you again to RCSLT for the opportunity to present this work, and we're happy to hear from you with questions or to engage in some of the questions that have come through during the presentation.
Oh, thank you, Rachel. And it's great to see the quantity and the quality of the research that you're able to pursue on these really valuable packages, which I do point students to and cover in teaching, but it's great to see the kind of evolution, really. So there are lots of questions coming in, and some of them are quite broad in theme, so I think we may push some of those towards the end, but there are some specific ones for now, and I think that I'll try and collapse a couple, if that sounds okay. So one of the specific themes is, you know, the contrasts and the pros and cons of in person versus online. And there are 2 specific themes which have come up there. One is how you're capturing dynamics of conversation online. I'll put both of these to you, and you can kind of deal with them as you see fit, really. But so dealing with the conversations online within a family, and the other theme is how you can create a kind of group dynamic in the online environment, you know, where it can be slightly more, just slightly harder work to kind of create that familiarity, for example.
Yeah, sure. So I guess in terms of the dynamic of conversations online, so I guess one aspect to consider there is that when we're working on communication partner training and improving conversations with that focus on upskilling the communication partner, what we're mostly doing is still observing an in-person conversation between the client and their communication partner. So we're still, I guess, providing feedback on an in-person conversation in a way. We're just looking at it from a distance. Having said that, I guess there are some challenges when you are working with a family over telehealth. Certainly there's a risk of missing some of those non-verbal cues, or you might not see the whole picture of what's going on. And certainly that was something that came up in our qualitative research, that you know, people did say that maybe we might have missed when they were losing focus or when they needed a break, missing some of those fatigue cues perhaps during the session that you'd pick up on when you're in the room with someone, but are a little bit more difficult to read over telehealth. So I guess there's some complexity there, and I guess a strategy to help to facilitate, I guess, that positive working relationship and to avoid missing those cues that we found was the need to ask a bit more directly about how people were going, asking if people needed breaks, In terms of complexities with family dynamics, sometimes that did look like maybe having a bit of a follow-up phone call after the session with the family member so that they could let you know what was really happening behind the scenes. So there did need to be a few workarounds like that that we considered. So I think that was the first element of the question. I'm just trying to regroup what the second element of the question was that you posed for.
Sure. Yes. So it was about how you kind of create the group dynamic.
Yes.
You know, any kind of tips for doing that practically, where, you know, it can be somewhat easier to be passive, or, you know, it'll take a bit longer to kind of build up familiarity, for example.
Yeah. So I guess calling back to Leanne's comment before, that group dynamic is really magic, and, you know, so much can be done when you're working with families in that group environment, those aspects of group support and that sense of, oh, you're going through the same thing that I'm going through as well. And, you know, that was something that we put some thought into in terms of how we could add that sense into TBI Connect, given, you know, that all the sessions are really just the clinician interacting with that family. So we did, one of the things we did was include some quotes from our qualitative interviews with families who'd been through the training recently, to give that sense of, this is what to expect. You're not going through this on your own. This intervention may be a bit challenging at first, but you'll get there with time. So that was one idea we had, to kind of add in that group dynamic, even though we were working with individuals. But I think in terms of that broader question about online interventions and group dynamics, that might be something that Liss can talk further about when she's talking about our Facebook groups and using social media to sort of build connections. So that's, I guess, another avenue open to sort of creating groups in an online space.
Sure. Thank you, Rachel. So some of the broader themes coming up are adaptability of these packages across cultures and across ages as well. So have a think about, we can broaden out to those wider issues really, in terms of, you know, across the lifespan, for example. But I think we'll move on. Thank you very much, Rachel. And I think we will move on to Liss, and then we'll come back together at the end for our kind of panel discussion. And yeah, please keep your questions and comments coming in, and I will try to deal with as many of them as is possible, really. So yeah, we're delighted to welcome the last presenter, Liss Brunner, and over to you, Liss.
Thank you so much. Hi, everyone. I'm Liss, and it's an absolute pleasure to talk to you about something that I'm very passionate about, and that's the use of social media after a brain injury. And I'll go to the next slide just to acknowledge that I'm actually joining everyone from unceded Ku-ring-gai lands. If any of you overseas ever come to Australia, please do come and visit our wonderful lands, because they've been looked after by our traditional custodians of the lands for many, many years. And I just always like to recognise that they've got this beautiful continuing connection to the lands and the water and to their culture that we love to pay respect to. Next slide, please. I'd also, like Rachael, like to acknowledge that I am employed at the University of Sydney, and even though I will be talking to you about how we developed social ability, and I'll be talking about a lot, I received no financial benefit from the program. Next slide. And so today I'll really be talking with you about the benefits and risks of online social relationships and using social media after a brain injury, and sharing with you some of the evidence of approaches and strategies to support social media communication skills, and also to really talk you through an example of a bespoke online program to support people with brain injury to use social media safely, but also so that they can enjoy it. Next slide. So we've been talking about how brain injury can be really quite sudden and traumatic, and the resulting changes in a person's cognitive function can really affect how they communicate and how they navigate their relationships. And so within a year, many people have lost most of their friends, and their remaining relationships are often quite strained. And so in rehabilitation, my main focus would be to support people to build their social communication skills with different people and in different spaces. Next slide. And so these days, one of the places that I feel we really need to consider is social media. The number of active social media users increases every year. We saw it jump during COVID times, but it has been steadily progressing, and around 60% of the world's population now use social media. And of those of us who use social media, we use an average of around 7 different social media platforms each month, which was something that I didn't really think about. And then I started thinking about the platforms that I use regularly and went, oh, that actually is probably quite accurate. Next slide. And so in terms of what social media actually is, there's lots of different definitions in the literature, but essentially social media is internet-based applications or software that allow people to create content. They can collaborate online and build communities and share this content through different network types. Next slide. And I quite like this Kaplan and Heinlein breakdown of the different categories of social media. And there's 6 main categories. And first of all, there's blogs, so things like WordPress, and there's collaborative projects like Wikipedia. And these ones are mostly text-based, and they only really allow for a fairly simple interaction between the users. But then you've got things like social networking sites, and Facebook and Twitter are fairly common ones, and content communities like YouTube and Tumblr, and they have text-based communication, but they also allow you to share different types of media and have a lot more interaction between their users. And lastly, there's virtual social worlds like Second Life and The Sims, and virtual game worlds like World of Warcraft, and I've put a couple of other examples there, that try to replicate face-to-face interactions, but in a virtual environment. So there's a whole host of different applications, including email, which actually fall under the umbrella of social media. Next slide. And there's lots of advantages to using social media. We know that it can create connections. We can definitely use it for entertainment and wasting time, but it's actually a really huge source of information and news for people these days. And it can be a really wonderful platform to share information and also advocate for greater awareness, particularly in speech language therapy. Next slide. And I just find it really interesting that with all of these uses, the number one reason people still use social media is to stay connected, particularly with friends and family. So I feel like it's a really important space where we are often having conversations. Next slide. So for people with a brain injury, using social media might really be a big benefit in terms of giving them access to social participation and inclusion in the community. However, in my PhD research, we found that people with an acquired brain injury can really find social media challenging to use, both enjoyably and also to stay safe while they're doing it. Next slide. And in terms of cognitive communication disorders, there's many examples of difficulties that we might observe during in-person conversations and interactions after a brain injury that we can also see would influence our online interactions. This is not an exhaustive list, but I thought I'd just put a few up here for you to consider. And so, for example, if someone had difficulties with attention and they're easily distracted, in social media, they may start responding to a post or get distracted and send some incomplete or completely illegible messages that could be misconstrued. If someone's got difficulties with emotional control and managing their feelings, they may get really overwhelmed with all of the information coming at them in their timeline, or feel really overwhelmed with lots of negative or sad posts. Or if they have difficulties with impulse control and they may not stop before acting, they could friend absolutely everyone who sends them a friend request, or they could post or comment on something without thinking about what they're saying and the potential repercussions of what they're saying. They could also totally overshare and be highly dominant in conversation. Next slide. And during my PhD, I did a variety of mixed method studies to really start exploring how social media might be used by people with a traumatic brain injury, and to get a sense of what was happening for them, and also for rehabilitation clinicians who might be needing to support people to use social media after a brain injury. Next slide. And at the end of my PhD, it culminated in a meta-synthesis where I really brought together all of the evidence that I'd collated throughout my PhD across multiple levels in quite a complex system. And I tried to break it down to something a little bit simpler. Next slide. And I identified 5 main guiding concepts that could inform the development of some evidence-based protocols, I suppose. And in this IJLCD paper, I also suggest some facilitators of how we can, of social media use that we could probably address in rehabilitation. And so I feel in using these main guiding concepts and the protocol, as rehab professionals, we can be more proactive because we've got a little bit of guidance. And so we can work with people to really develop person-centered goals that address their social communication in digital contexts. Next slide. For each concept that I identified, I pulled out a facilitator out of the protocol here for you to see. I'm not going to go through all of them, but I thought I'd give you an example. So for when we're trying to determine a person's purpose for using social media, it's really important to identify the digital systems that are personally meaningful for them. And so a simple strategy would be simply to discuss and clearly document which social media platforms the client uses with both them and also their family and friends, and to look at which platforms they prefer to use and why. Next slide. And so my PhD research really provided a roadmap for lots of different avenues of inquiry in terms of looking at social media use after a brain injury. And today I wanted to share with you a little bit about the results of a scoping review that we've conducted, and also the development and pilot of social ability, which is part of the Social Brain Toolkit. Next slide. And so in terms of when I finished my PhD, we were talking about, well, what sort of training might there already be out there that could be readily available for people to use, that could guide not only the person with brain injury, but also clinicians to build their skills in social media use. And so we conducted this social scoping review and focused on the key issues that should be addressed in social media training for people with a brain injury. And the link for the paper is there. Hopefully some QR codes are going to work today. And next slide. In the scoping review, we really identified that there was a huge need for interactive training that's co-designed, that's safe, that incorporates practical components that support people with brain injury. Next slide. And we also identified that the training should actually address all of these different aspects on, so for example, how to basically just use social media, aspects of social participation, cover things in professional use as well as personal use, because we're using social media more and more in our workplaces, but definitely we would need to address aspects of cyber safety and well-being. Next slide. What we didn't find was any social media training resources that were immediately accessible or relevant for people with a brain injury that they could just pick up and run with straight away. And so we felt that there was a need and wanted to address that gap. Next slide. And this led to the start of social ability, which is part of the Social Brain Toolkit that Rachael was speaking about in terms of conversibility and interactability. And social ability sits alongside these programs because it's an online program, but it's to address social media use in particular. Next slide. And as part of Petra Avramovich's PhD research, she also led this co-design process where we asked people with brain injury and other key stakeholders to give us ideas on what things should be included in social media communication skills training, and also how it should be presented. And so initially we asked them about course accessibility, the content, the format, and what they felt were really key priorities for this type of training. And then their suggestions were incorporated into designing draft prototype ideas, and we showed them these ideas and got further guidance and feedback before we moved further. Next slide. After we designed a prototype, we then ran a pilot study with 4 participants with brain injury who tested out the prototype of the program for us. And overall, they felt it was quite a valuable resource. And you can see here one participant said, I reckon to other people who had a brain injury like me, I'd really benefit so many things from it. And essentially they found the program acceptable, engaging, functional and accessible. But they also gave us lots of feedback on what they thought didn't work. And we used their feedback to further refine the program before we moved on to the next phase of testing. What we didn't see was any change in how often they used social media, but we did see a change in their confidence, which improved. And they also reported being more aware of how and who they interacted with in social media. Next slide. And so we refined the prototype a little bit further, and I thought I'd just give you a little sneak peek of the components of the program. Next slide. And so you can see here the 4 modules of the program, and it takes, depending on the person and how they're doing it, around 2 to 3 hours to work through these 4 modules. Which are targeting what is social media, staying safe in social media, how do I use it, and who can I connect with? And even though there's a specific module on staying safe, threads of cyber safety are actually woven throughout all 4 modules. Next slide. In the modules, there's a combination of simple written information, and in these we've tried to incorporate lots of white space, simple graphics to really support people's understanding, and built in some simple accessibility features like being able to change the font size or the contrast on the screen. Next slide. There's also videos, and in these videos we also provide a written transcript and closed captions, and also summary for people to access. Next slide. And even though I don't have time to share with you one of the videos, I thought I'd give you a bit of a snapshot of some of the content of one of the videos, which is in the course. And this is in the How Do I Use Social Media module. And it really prompts people to think about how much time they spend using social media and gives them some practical tips on making social media really work for them. Next slide. We also have incorporated quite a few questions for people to work through, and we've based a lot of these around practical examples of using social media. Next slide. There's also a printable worksheet for people to write down and keep the key messages of the 4 modules, and there's prompts throughout the program to use the worksheet like this one on screen. Next slide. Similar to interactability, people can actually work through this at their own pace. They don't have to do all 4 modules. They can pick which module they choose and go backwards and forwards between them, and they can save their progress. And if they're interested, they can get a certificate of completion after they do all of the modules. Next slide. So we knew that the social ability program was positive benefits for the pilot study participants, but they also had some trouble getting through it by themselves. So we wondered whether adding in practice and peer support, so that group element, changed the outcomes for people. And that led to a pilot study where we combined the use of social ability with a social media practice group. And so we used a mixed methods pre-post intervention design to evaluate this, where essentially we asked people with brain injury to complete the social ability program, and then we invited them to join a private moderated Facebook group to practice their social media skills and communication over a 12-week period. And we had a moderator from Brain Injury Australia to support that group over the 12 weeks. The purpose of the Facebook group really was to encourage the participants to participate and engage and connect through giving them opportunities to practice their social media communication skills in a really safe and supported way. And that's one of the really big benefits of the closed Facebook groups. We developed a 12-week program of topics to discuss, and this is just some examples of the topics that we used. And at least one post per week in the group focused on a social media function or a safety related topic. Next slide. Sorry. And we'll move to the next slide again. So 16 participants completed the 12-week intervention over the 2 groups. We collected data on several aspects of their social media knowledge, use and enjoyment, and quality of life at pre-intervention, post-intervention, and 3 months post. Next slide. And in terms of their social media skills, after the 3 months of being in the group, 9 participants showed an increase in their knowledge of romance cyber scams, and 11 were able to give more specific advice about what they do in response to a cyber scam. Next slide. And 5 people increased their knowledge of what hashtags actually were, and 7 people were actually able to generate hashtags themselves. Next slide. 3 months after the group had finished, 15 people had maintained their knowledge of cyber scams and 13 had maintained their knowledge of hashtags. Next slide. We, again, didn't see any change in how often they used Facebook, which is really similar to what we saw with pilot participants. Next slide. But what we did see were significant improvements in their confidence in using Facebook and also in their enjoyment of using it to connect with other people like themselves. Next slide. And so even though there were no significant changes in reported quality of life, the participants all reported multiple benefits from the intervention. And so it gave us some really preliminary evidence of some benefit to this intervention. And the people in both groups recommended that others should totally give the program a go. Next slide. Last year, we actually ran a 3rd group, and we're in the process of analysing the outcomes and interviews from this study. But in this study, we actually had the ability to engage 2 people with an acquired brain injury to be peer moderators for the group. And I've got to say the engagement was quite different and the dynamics were quite different. So watch this space. It'll be really interesting to see the results. Next slide. So we're pretty pleased to say that Social Ability is now available for free on our website. So the link and the QR code are there on the slide for you. And so if you want to go and check it out, you're freely able to do that. And we'd love feedback on your thoughts on it as well. Next slide. But I really wanted to point out that this is actually just a starting point. It's an ongoing process of building these social ability resources. We're now starting to work on building and trialling an online social media communication assessment tool. And then we want to co-design a clinician-directed intervention program. And there's so much potential for this work to be adapted for other people that may interact clinically, that we may interact clinically with. So again, it could be working with people with dementia, or it could be young people who have a developmental language disability, or people with autism. Next slide. On the next slides, I've got some of the references to my thesis papers, and on the following slide are our latest publications in this space, and they're all open access, so you can read about the background to all of this work. But on all of our slides, I think we've all had our Twitter handles, so I'd like to encourage people to reach out to us on Twitter as well. But I've also recently joined Mastodon because of changes in Twitter, but we would love to talk to anyone about all of these things. That's all from me. Thank you very, very much.
Thank you very much, Liss. Fantastic project. So a specific question which has come up is, how do you, so when you facilitated people having more contact and better quality of contact through, say, Facebook, how do you kind of withdraw yourself? So what are your strategies for making sure that, you know, you don't need to be the crux keeping the kind of network together, if that makes sense?
Yeah, it's really tricky, actually. So when we set up these Facebook groups, we had some ground rules to start with. And so we actually consciously asked each of the participants if they wanted to join the Facebook group as themselves, because they'd be meeting new people, and they may not necessarily want to stay in touch after the research project. And so all but one participant joined as themselves using their regular Facebook account, but one person actually has two accounts. One's a personal account and one is one that they set up specifically after they had their brain injury to interact with brain injury support programs and things like that. So they were already actively using two different platforms, two different accounts, to interact kind of with two different communities within Facebook itself. So that was kind of one of the first things that we set up. And we also made it clear that we wouldn't be friending people. So there wasn't going to be that reciprocal relationship necessarily, that, you know, everyone would be free at the end of the 12-week program to reach out to other participants if they wanted to stay in touch, but recognise that that may not occur. And that was the same for the moderators like myself. Rachael was one of the other moderators in the group as well. And so that was one of the ground rules we went in with. We had these all in separate groups, our 3 different groups, and we've actually merged them into one group following the official research time, so that the people in the groups could actually keep conversing and interacting. And I've got to say, it's quite sporadic, and so people will sort of jump in and out. But one of the things that we set up to facilitate that feeling of community was in the initial 12 weeks for the first 2 groups and the shorter amount of time for the peer-led group, we set up semi-regular Zoom meetings. So like a morning cup of tea session. And that meant that people could connect with faces and talk about where they lived in that real synchronous, in the moment kind of style of conversation, which you don't necessarily get in typing a response in Facebook. And it was quite invaluable to helping build that feeling of connection. And I think also for building longevity. And so Rachael and I attend the Zoom meetings, but it's actually the peer moderators who kind of lead those meetings. We support the admin of it, so to speak, but it's really led by the participants. And so we try to have semi-regular Zoom catch-ups still. But yeah, it is quite sporadic. So having some support can be really beneficial. That's one of the strategies we use.
So it sounds like there's quite a kind of subtle process of you trying to kind of hand over those reins, really, which sounds really, really interesting, challenging, but really important. Fantastic. Well, thank you so much. I mean, I think there are so many questions who have come in. I've been trying to kind of look at them and kind of cohere them into some themes. So I think in our last kind of 7 or 8 minutes, I think I'll open it up and see if we can address as many of those as possible. So one kind of repeated query has been about resources, and I think it's fair to say the whole point of you know, the INCOG and the general availability is to make them, you know, accessible to clinicians, so we can make sure that works after the podcast today. But just looking at the kind of themes which have come up across questions, so one has been to do with, and this is open to Leanne, Liss, Rachael, adaptability. So, you know, within the epidemiology of TBI, we have kind of clusters. Obviously, anyone can have a TBI. We have clusters, maybe late teens, early 20s, maybe people in their 60s, 70s, maybe young teens as well. And how do you feel these approaches should be kept specific and tailored to different age profiles, or can you kind of bring ages together? And are there challenges in implementation there, for example? Leanne, do you want to lead on that? Yeah.
Yeah, I'm happy to answer that. I think when it's interesting, as you know, this body of work's been now going for well over a decade. And I think when we first started, we had an age range of 16 to 65. That was our but as we've progressed, and older people are surviving their TBIs now, whereas they used to not when I first started working many years ago. And I think just because somebody's 70 doesn't mean they're old. So we've actually extended our age ranges when we've been collecting data, for example, to older participants. And, I think generally it's been fairly successful. I think we've managed to cover the entire age range. Depending on which program you're talking about, sometimes even with TBI Express, our three groups, we did 3 waves of data collection. They were different kind of groups. They were different parts of Sydney. They were different demographics, different socioeconomic status kind of groups. And so it really does depend on who turns up. And I think that's where you need that expert clinician expertise to be able to target what you're doing to whoever's in the group. And that brings it back. We did always have individualized goals for whatever program we've talked about today, in combination with a more manualized process of how we go about teaching particular tasks. So I think it can, these programs can be adapted because we've always kept that individualized goal setting and goal attainment scaling, those kind of measures.
Fantastic. Yeah. Okay. And what about?
I'll also just point out, Paul,
Sorry.
our eldest participant in our social media groups was actually 81, which for a social media intervention might surprise some people. So I feel like, these resources do need to be adaptable across different ages and contexts.
Sure. So it sounds like there's a really critical ingredient, which is that the set format and the group work, for example, is worked in parallel with a lot of individual attention and a lot of almost kind of 50-50 tailoring. So you've got the format, but you've also got the one-to-one. Okay. And how do you feel that would that lend itself to the kind of cultural adaptation? So one of the questions that's come up a few times has been the international perspective, sort of moving beyond maybe the white monolingual English cultures, for example. Have you any? You may not have data, but have you any thoughts on that kind of future horizon?
And I think it's something we were conscious of, particularly with developing interactability, to sort of make sure that in the imagery we were had that representation. And one of the key parts of interactability was to work with 4 different families to tell their stories about acquired brain injury. And so, one of those families is from a Vietnamese background, for example. And so we have started to take steps in that direction, I think, but there's certainly a lot more that we could do in terms of, seeking advice about where we might need to modify these programs to be more culturally appropriate, to work with researchers from different cultures as well to kind of test out the outcomes of these interventions with different groups. So I think we're taking steps, but there's a lot more that we could be doing as well.
Yeah, sure. Work in progress. And I think research funding is increasingly being tied to at all levels, tied to EDI and really thinking about the variety of cultures within each clinical setting, really. Okay. Maybe just mindful of time, and maybe for our last 2 or 3 minutes, what about communication from these interventions across diagnoses? So some of the points which have come up have been to do with, this work sounds vital to my work with people with a learning disability or stroke or dementia. And there's a beauty and a kind of rigor in starting with one diagnosis, but I mean, are we at risk of kind of, having to kind of reinvent the wheel in different settings, so to speak?
I think that's why we've got ABI in all these later terms, because we've got to that point Paul, where we, so interactability, for example, has an example of someone with a stroke, with aphasia. We have someone with dysarthria, someone with cognitive communication disorder. I think we have recognised that in our own work, that, and you know, we're doing this adaptation for dementia, which I don't know what that'll be called when it's done, but I think there are some elements to some disorders that obviously are going to need tailoring to that particular disorder. But I also think there are commonalities. And I think when we talk about cognitive communication disorders, now we're not just talking about TBI, we're talking about right hemisphere disorders, we're talking about some elements of, you know, the language of people with autism, because there are a lot of commonalities, and dementia is another one. You know, I view that as a cognitive communication disorder. So I think we can adapt what we've done. I think we need to do it in a rigorous manner. But I think there's definitely potential there. And like conversibility, for example, you know, if someone had a very high level aphasia, I think it would be a reasonable program for them to go through. It's you know, I think we've tried to broaden things out a bit so that they are more inclusive of other disorders.
Sure, absolutely. And I think you've achieved hugely that balance between definition and flexibility and adaptability. So we have to get good evidence somewhere, and then we adapt that and we kind of tailor that in other contexts. Brilliant. I don't think we could ever do this justice, really, could we, in terms of, you know, the number of issues and questions which flow. But I think we probably should leave it there, bearing in mind it's evening for you, and clinicians will be moving on to their busy days. But just to say thank you ever so much again, and to RCSLT for hosting, and we'll do our best to follow up to make sure that, you know, that attenders can access resources. And yeah, just to close the proceedings now with a big thank you to everyone involved. Thank you very, very much.